The next speaker is Dr. Rahul Valtraj from Kochi. The topic of discussion is glucometer, what a clinician should know.
Good morning to everybody, and first of all I'd like to thank the organizers for giving me this kind invitation to speak in this massive auditorium, and it's great to be back in Kolkata again. The glucometer or the glucose meter is arguably one of the greatest inventions after insulin that we continue to use in daily practice, and we as clinicians need to know the advantages and the limitations so that we can interpret the reports correctly and also guide our patients and our nursing team and the hospital staff regarding the correct use of these glucometers. So the initial reports of point-of-care testing was reported in 1500 BC, where Egyptian physicians used to use ants to check for glycosuria, the glucosuria in the patient suspected with diabetes. And in 1960s, the dextrose sticks was invented, which is actually a paper. It's a paper strip which turns blue in color depending on the glucose concentration in the blood, and it is similar to our urine dipsticks, and you can compare the color and then you can interpret. And following in the 1970s, you have the first glucometer which was invented, that is the Amy's reflectance meter, which uses these dextrose sticks to quantify the amount of glucose which is there in the blood. So mainly we use for SMBG, which is a cornerstone in diabetes management, and also we use it as a point of care testing in our OP, IP, emergencies, ICUs, and emergency and in ambulances as well. So what are the advantages? You get the results immediately. That is one of the main advantages. It is relatively painless. You require a very small amount of blood, and a single person can do it compared to your venous sampling. The disadvantages are, of course, the cost. The glucometers might be little more cheaper, but however, the cost of the strips is a lot. They have short expiry dates. It is operator dependent, and because of the operator uses, you can have variability, which can be pre-analytic, analytic, and post-analytic. And the older machines, you require calibration or coding, which is not there with the newer glucometers. In fact, because of its cost, in the US there is a second-hand market for these glucometer strips. So most patients procure these strips through insurance, through the insurance companies, and they get it free of cost. And people with extra strips can sell it, and that is further resold to other poorer people without insurance. So most patients ask us, okay, the glucometer, is it accurate? Which glucometer should I buy? What is the difference between the glucometer reading and the lab values? So why is accuracy important? Because we take therapeutic decisions based on these readings, be it titration of insulin or the oral anti-diabetic drugs, especially for hypoglycemia. We need to know immediately and treat immediately for the diagnosis and treatment of hypoglycemia. And of course, we do sometimes calibrate CGM machines with the glucometer as well. So there have been many standards that have been set. There are international standards, the most recent of which is the ISO 2013 standards. And if you're comparing the actual glucose with the blood glucose reading, 95% should fall within, if the blood glucose is more than 100, 95% of the time it should fall within 15% of that value. If it is below 100, it should fall within 15 milligram per deciliter of that value. And if you're looking at type 1 diabetic patients, 99% of the time it should fall within this gray area, that is the zone A and zone B of this graph. So there are many studies which have compared the accuracy of glucometers, which I have shown here is an American and a European data. So in the American data, they showed that only 33% of the meters met the ISO standards. Another publication from Europe showed that 77% met the ISO standards. And in India, as you know, there are so many brands which are available. Which one is standardized, which one is not, we have no idea. And these tests are done mainly in the lab by trained technicians. So how reliable are these tests are these results in real life as well? Because there are patients who are doing it, there are other staff who are doing it, and the scenario is totally different than the lab. So again, the results may vary in the real world scenario. So what are we measuring? We are measuring the capillary blood glucose. So what is the difference between the venous and the capillary blood glucose? I'm sure most of you know. In the fasting state, the capillary blood glucose is somewhat same as the venous blood glucose, but in the postprandial state, the capillary blood glucose is around 10 to 15% higher. If you're comparing whole blood and plasma blood, the plasma is higher than the whole blood because of the presence of the RBCs. And if you're measuring the whole blood glucose is definitely, it can vary with the hematocrit level. So the higher the hematocrit, the lower the plasma glucose, and lower the hematocrit, the higher the plasma glucose. So the International Federation of Clinical Chemistry, they have recommended that all glucometers should give the reports of the plasma glucose. So even though you're taking the capillary whole blood, what is shown in your glucometer is already calibrated to show the plasma glucose values. So the main brain behind this whole glucometer is the glucometer strips. So the glucometer strips are of different types and different companies have it. So essentially it consists of the coating and the sample chamber layer where the blood is applied, and there is a liquid attracting layer, so which absorbs the blood, and you can see the blood going inside whether it is adequate or not. And then you have the chemistry layer, that is where the enzymatic reaction takes place, and the electrons are transferred further into the circuit. Circuit can be, it's the electrode which can be made of gold or palladium, and then the results comes in the glucometer. So the most essential part is the enzymatic reaction, where the enzymatic reaction takes place, and the electrode. And most glucometers now use their enzymatic amperometric blood glucose biosensor. So they also used to be a colorimetric or photometric biosensor, but most new glucometers use the amperometric ones. The enzymes which are mainly used is the glucose oxidase and glucose dehydrogenase. Hexokinase is not used anymore with most commercial glucometers, and the electrodes, as I mentioned, can be gold or palladium. So you have 3 different generations, even a 4th generation. So majority are one of the first 3 generations. So you have the enzymatic reaction which takes place, which can be glucose oxidase or glucose dehydrogenase. You have cofactors, and also you have mediators. So mediator is there in the 2nd generation, and in the 1st generation it's mainly oxygen getting reduced to hydrogen peroxide, which transfers the electrons to the electrode. So if you look at these 2 systems, the glucose oxidase assays are mainly, it is highly selective for glucose and it is dependent on dissolved oxygen. And if you look at GDH based assay, it is low selectivity for glucose and independent of dissolved oxygen. It is important to know it because you will see in the coming slides the variations that can take place with respect to these assays. So if you look at the major players, so the most of the market share is by, you have your different companies, Bayer, Abbott, Roche, you have LifeScan. So if you look at all these, most of these glucometers use the GDH based systems, and LifeScan or OneTouch, it uses the glucose oxidase based. So whenever a patient is buying the glucometers, you should tell the patient or the hospital staff to see which kind of a glucometer is being used, which assay is being used. So with regard to variability, so when you are looking at the actual blood glucose and the blood glucose reading, there are many factors which can affect the blood glucose, the actual blood glucose and the glucometer reading. There are many factors which can affect the readings. And each and every small factor can be additive. So there might be 1 or 2 factors here and there, and the whole blood glucose can vary by around 15 to 20% even. Majority of the analytical variability occurs due to incorrect handling of the glucometer. So human errors such as not washing hands, the dirty meters, improper strip insertion, improper sampling, not properly stored strips, not correctly performing coding, especially with the older meters, and no proper education regarding the whole technique of using it. The meter inherent factors also can play a role with regard to the accuracy of the standardized meters or not, and also the user friendliness of the software. Strip factors also play a role, while-to-while variability, lot-to-lot variability, and strip-to-strip variability. Environmental factors such as altitude can play a role because the oxygen tension is different at high altitude. So when there is low altitude, low oxygen tension in the high altitude, you can have a falsely higher reading. Humidity and temperature is usually with the older type of strips, which uses mainly photometric or colorimetric. Even the newer strips can have few variations with humidity and temperature. There was one study showing that maybe mobile phones can also cause, but again we need more data regarding that. The electromagnetic waves from these mobile phones can cause a variation, and this study recommended that there should be a 50 centimeter gap between the glucometer and the mobile phone. Now this is an important slide because there are many physiological factors which can affect the glucometer readings, with especially hematocrit, as I mentioned earlier. Because of a high hematocrit, you can have a mechanical impedance or an increased blood viscosity, which can cause a falsely low reading. Anemia can cause a falsely high reading. Oxygen and pH plays a major role in mainly glucose oxidase-based system. As I said, it is oxygen dependent. So if you have hypoxia, you can have a falsely high reading. And if a patient is on oxygen therapy, you can have a falsely low reading in the glucose oxidase-based system. And with regard to pH, if you have acidosis, you can have a falsely low reading. So acidosis, they have said that the falsely low reading can come with a pH less than 7.9, 7.8. So especially in patients with diabetic ketoacidosis, we need to be careful while using these glucometers. Ascorbic acid and acetaminophen, again, they consume peroxidase. So because of that, in the glucose oxidase-based system, it can show a falsely low reading. It's usually seen in very high doses of ascorbic acid and even with paracetamol poisoning. Another important part of the slide is maltose, galactose, and icodextrin. So icodextrin is again used for peritoneal dialysis, and there are reports that because it has a similar structure with glucose isomers, because of that it can interfere mainly with the glucose dehydrogenase system. So the system with glucose dehydrogenase, we need to be careful if the patients are on fluids containing maltose, if you have galactosemia, and also patient on peritoneal dialysis. So these manufacturers, in fact, they made a modified glucometer. It is also called a mutant GDH PQQ glucometers, so that this interference is taken care of. But we have again two publications, one from my senior consultant who I'm working with, Vivek Matthew sir, and one from Kolkata, Partho sir and his team. They've shown that with these new glucometers as well, you have erroneous readings. So we need to be careful while interpreting the readings. Especially with patients in critical care illness, you have a combination of all these physiological factors with change in hematocrit, patient with shock, on inotropes, patient on oxygen, patient with acidosis, patient may be on peritoneal dialysis as well. So we need to be careful while interpreting the glucometer readings. Probably maybe the GDH systems might be preferable because especially for hypoxia and acidosis, mainly the glucose oxidase systems are the ones which are more effective, which are more having interference. But again, if the patient is on peritoneal dialysis getting IV, IG, which is a maltose containing fluid, then we need to be careful. And finally, regarding the post-analytical variability. So mainly it's regard to reading the glucometer readings and also with data entry, especially by the nursing staff in the file, the hospital file. So if you look closely at these two diagrams, the first one, if a nurse or a patient sees 53, the patient might get very worried. Oh my God, I'm in hypoglycemia. The sister might call the doctor, patient is having hypoglycemia. They might pump the patient with dextrose. But if you closely look at it, it is in millimole per liter. There is a decimal point, which might be missed by many elderly patients who have poor vision. So actually the patient has a normal blood glucose. So if you look at the other one, patient might say that, okay, it's 139, it's completely normal. But actually it is 13.9, again it's in millimoles per liter. So many patients do come from outside, NRIs, they usually bring imported machines which might already be giving reports in millimoles per liter. So we need to be careful regarding that. Many patients who frequently check their glucometer, frequently do SMBG charting, so they might complain of pain at the fingertips. So there are many alternate sites which can be used, and many glucometer manufacturers have different sites which are recommended by them. So we need to check with the manufacturers which can be used. And there's also a study from JIPMER which compared the palm, that is the thenar and hypothenar eminence, with the fingertip, and the palm was found to have a lower, it was less painful and had less variation compared to the fingertips. Lancing depth, again, the depth of the prick, again, it is directly proportional to the volume of the blood and the pain experience, and the lancet gauges don't there is no significant difference between the lancet gauges. And another dilemma is with regard to whether to discard the first drop or not, or whether to milk or not to milk, that is whether to squeeze or not. So a study in diabetes care showed that if you're washing your hands and drying properly, you can use the first drop. However, if you are not able to wash the hands and if you have recently had a fruit, so it is better to use the second drop. And firm squeezing should be avoided. So minimal squeezing is okay, but very firm squeezing should be avoided. Regarding cross infections also, it is shown that around 40% to 50% of glucometers have been contaminated, and also bacterial contamination is also seen, especially if you're using containers with vials. If you're using single pack strips, then the chance of bacterial contamination is much less. So the CDC has actually recommended not sharing the glucometers. However, that is not feasible in India. So it is better to disinfect the glucometers and also frequently change gloves and use individually packed strips. So my take-home point is always insist on ISO standardized glucometers. It is important to know the enzyme method of which the glucometer is working with, and the clinical background and the physiological background is important. It is important to educate your team regarding the use of the glucometer and also the patients. And when in doubt, always confirm with a venous lab sample. Thank you.
Thank you, sir. Now we will having questions from the audience. Few quick questions. Otherwise, we'll conclude the session and move forward.
Thank you very much. Then should we discard the glucometer in the long term? What is your idea?
Discarding glucometers will be, again, the cost is another issue. So, yeah, there are newer generation. It's like changing our iPhones or changing our mobile phones. So, there is definitely newer technology which is coming. So, if it is a very old glucometer, maybe more than 10 years, I think it's better to use a newer technology. But again, to tell a patient to discard it is something which is difficult to do.
Then can we think of non-invasive glucometers? Is it possible to develop?
Yes. So in fact, I have used non-invasive glucometer, and I have shared the glucometer with Dr. Prem. So what I found that is the readings are totally, it is not reliable at all. So there are many prickless glucometers which are there in the market. There's a Chinese one, and one which is made in Hyderabad by an IIT team actually. So I pre-ordered and I got it, I think maybe 3 to 4 months back, but again it was not reliable at all. So I don't advise using that as of now.
I think Chinese kits are always unreliable.
So I'm saying that I ordered the Indian ones. It is made by the IIT team from Hyderabad.
Thank you.
Rahul, nice talk. This is just a comment. So, before taking the sample, we should allow some time for free flow. This is number one. Number two, before taking the drop on the strip, some of the patients might have hyperhidrosis, and because of anxiety in the clinics, they might have sweat. So that's why we should not to take the first drop or the second drop, because it can dilute the sample and that can give erroneously low result. Now I'm coming to Dr. Ritesh. So you know that there are some differences between CGM and AGP. So which one you recommend?
Day-to-day practice, sir, I think AGP will gives us a better idea over a 14-day period of time to evaluate and to read ambulatory glucose profile.
And Prem, you have a nice talk.
Sir, thank you.
So can a patient's HbA1c be 0%?
Yes, that was the
What
situation.
should we do in that case?
So always look for the hemoglobin variance and even the LAVA A1C, which I showed one example, and looking into the graph and clearing out all the clinical situation, then you can try with the other methods also. Thank you, sir.
In case of, I have a question for you, sir. In case of hemoglobinopathies, we have the other turbidimetry, nephrometry, antigen antibody based method. In your experience and as far as the clinical papers go, how far do they tally with the actual HbA1c, which you are not being able to estimate when you have a hemoglobinopathy by HPLC?
I mean, in my experience, I have not encountered any hemoglobinopathy so far, I would say. So if ever you have any clinical situations where you cannot assess or you are not able to assess correctly the HbA1c, then the AGP one is the one that you can always better areas, because hemoglobinopathies or the HB involvement, hemoglobin is already involved, and you have the other forms, variants, and so definitely erroneous values as you have presented, you can expect all those things to happen. So better would be either an SMBG if the patient is very poor, self-monitoring of the blood glucose is one option, or if an affordable at least 4 to 6 monthly with the AGP monitoring, that will also suffice.
Another small question, in our day-to-day practice, people on oral hypoglycemics, they keep on estimating fasting and BP and they keep on sending reports. So how do you think it should be practiced in comparison to laboratory venous sampling?
Self-monitoring of blood glucose value, we have a definite set of guidelines. Type 1 diabetes, as you see, we always go for at least, the best one will be a 6-point SMVG monitoring. Practically, many times, kids, it's not possible. So at least a 4-point SMVG. What I do it in my practice is what I'm telling. At least I ask them to check every 2 to 3 days and send it to us. Type 2 diabetes, we have some leverage. So we can ask them to check at least weekly once, if only on oral anti-diabetic medications, a weekly once monitoring, that would definitely suffice. Thank you, sir.